Adamantinomatous carcinoma containing teeth. Craniopharyngioma is a type of brain tumor derived from pituitary gland embryonic tissue that occurs most commonly in children, but also in men and women in their 50 and 70. Patients were present with bitemporal inferior quadrantopenia leading to bitemporal hematopenia of the tumor may compress the optic crest. Craniopharyngioma are typical very slow-growing tumors. They arise for the cell along the pituitary stalk, specifically for neat or odontogenic epithelium within the suprahilar diencephalic region and therefore contain deposits of calcium, which are evident on X-ray. They are classified by histology as benign.
This is a 66-year-old woman with a history of headaches and cognitive changes. She's also had some ataxia. Her imaging demonstrates here in a coronal non-enhanced and an enhanced image a tumor filling the third ventricle. The key here is that the pituitary stalk is not displaced. It's in its native position, which is a tip that the tumor is within the third ventricle, and we'll choose a transventricular approach here to remove the tumor in an effort to preserve pituitary function. Do a transfrontal approach with the incision drawn here. Transcortical, and you're looking at the foramen of Monroe. Choroid plexus is in the field, and the tumor is evident filling the third ventricle. So we'll carefully dissect the tumor with microdissectors off the wall in a circumferential fashion. Dissection continues using microdissectors, in this case rope and cup forceps. The tumor is dissected completely and the floor of the third ventricle is left intact. The patient had normal pituitary function several weeks after surgery. The next patient is a 64-year-old male. Presents with several months of dizziness and unsteadiness. He's had 2 falls and has had headaches as well.
Craniopharyngioma treatment: balance disorder, dry sky, fatigue, fever, headache, hypersomnia, lethargy, myxema, nausea, short stature, polydipsia, polyuria, vision loss, vomiting, weight gain. Craniopharyngioma treatment generally consists of the subfrontal or transsphenoidal sections. Surgery using transsphenoidal router is often performed by a jointing and the neurogenes because of the location of the craniopharyngioma near the brain and skull base. A surgical navigation system might be used to verify the position of surgical tools during operations.
Craniopharyngioma is a rare benign tumor that occurs in the pituitary, both in the gland itself as well as in the stalk, which is the stem that connects the brain to the pituitary. They occur in both children and adults, in fact occur equally commonly in children and adults. These tumors can present with vision loss, or they can even harm hormone function. The primary treatment for craniopharyngioma is removal of the tumor through surgery, but this can be very difficult sometimes to cure, as a tumor can grow into areas of the brain that are so delicate that surgery could be damaging. So the endoscopic endonasal approach has become really a favorite approach for treating craniopharyngioma. It provides us a corridor into the tumor without touching the brain, or more importantly, without touching the eye nerves, the optic nerves. Often vision is significantly affected by these tumors, and we can sneak in under those nerves and also under the brain by coming through the nose and landing directly on the tumor. One of the more difficult areas of the tumor sometimes is also where it expands up into the brain. The endoscope allows us to see very closely that interface with the brain, and I think allows us to preserve both that function as well as the function of the eye nerves.
Malignant craniopharyngioma are usually successfully damaged with a combination of adjuvant chemotherapy and neurosurgery. Recent research described the rate occurring of malignant transformation of these normally being tumors. Malignant craniopharyngioma can occur at any age, are slightly more common in females, and they usually of the Adamantinomatous type.
A brain tumor is an abnormal growth of cells within the brain, which can be cancerous or non-cancerous. Brain tumors are categorized as either primary or secondary. Primary brain tumors originate in the brain and can be either benign or malignant. Secondary brain tumors, also known as metastatic tumors, are more common and are malignant tumors. Metastatic tumors spread to the brain from some other part of the body and mostly occur in patients who have cancer in the following areas: colon, breast, kidney, lung, skin, and various other places. There are over 100 types of brain tumors, but they can be broken down into two categories: benign and malignant. Benign tumors are not cancerous but can cause severe pain, permanent brain damage, and possibly death. They grow very slowly and rarely spread to other parts of the brain or spinal cord. They can be completely removed without causing any permanent damage and are very unlikely to recur. Benign tumors are considered low-grade tumors. Malignant tumors are almost the exact opposite of benign tumors. They grow rapidly and can spread to other parts of the brain or spinal cord. Even if a malignant tumor is completely removed surgically, there is a high chance of it coming back. Malignant tumors are considered high-grade tumors. Glioma tumors are one of the more common tumors and can be classified as either benign or malignant. A glioma tumor grows from a glial cell, and there are many different types of gliomas, such as astrocytoma, oligodendroglioma, ependymomas, brainstem glioma, and mixed glioma. Astrocytoma tumors begin in astrocyte cells in the cerebrum and cerebellum. These cells form astroglia, which are star-shaped cells that surround neurons in the brain and spinal cord. They outnumber neurons by about 50 astrocytes to every one neuron. Their purpose is to maintain, support, and repair the nervous tissue, and also to regulate synaptic transmission by creating and releasing glutamate. There are 4 grades of astrocytoma. Grade 1, a slow-growing, benign tumor that rarely spreads and occurs mainly in children and teens. Grade 2, a low-grade, slow-growing tumor that often spreads into nearby tissue in adults between the ages of 20 and 40. Grade 3, a cancerous tumor that grows rapidly and spreads to nearby tissue mainly in adults between the ages of 30 and 50. And Grade 4, an aggressive tumor that spreads and grows rapidly in adults between 50 and 80. Astrocytoma tumors account for 10.3% of all tumors.